Assalamu alaikum. My name is Dr. Amara Kazi, and my topic of presentation is surgical management of the BPH related LUTS. Today, we are going to study about some open surgical techniques for simple prostatectomies and the laparoscopic and robotic approach. Our objectives today will be the indications, contraindications, preoperative evaluation and preparation, surgical approaches, and the post-operative care complications along with the follow-up. Anatomy, first of all, before learning the surgical techniques, it's important to review the anatomy of the prostate. It's basically roughly the size of the walnut and the inverted cone-shaped gland with the apex facing inferiorly above the external urethral sphincter and the base upward just below the bladder neck. The prostate um, is covered with a thin fibrous capsule that resembles the thin connective tissue of the large vessels, that is adventitia. The important relations of the prostate is that anterior to the prostate lies the pubic symphysis, and the anterior surface of the prostate is attached to the pubic symphysis by the puboprostatic ligament. Superiorly lies the bladder leg, inferiorly the urogenital diaphragm, and posteriorly the anterior wall of the rectum. The posterior surface of the rectum is separated from the anterior wall of rectum by denovular fascia, which is the fibrous remnant of a rectovesical pouch. And anatomically, the prostate is divided into the four lobes, into five lobes: anterior and the posterior lobe, two lateral lobes, and the medial lobe. And histologically, the central transitional zones and the peripheral zone. Peripheral zone being the most common site for the carcinomas, and the transitional zone being the most common sites for the benign hyperplasia of prostate. Some of the indications for simple prostatectomy, the absolute ones are enlarged prostate with that is more than the prostate measuring more than 80 grams with the urinary bladder diverticulum or bladder stone. The other is enlarged prostate along with the orthopedic conditions such as the femoral fractures or the osteitis fibrosa, which hampers the lithotomy position to be made. Other are the complex urethral conditions such as urethral strictures or any previous reconstructive surgery of the urethra. Enlarged prostate along with inguinal hernia, so that inguinal hernia can be repaired along with the removal of the prostate gland. And it can also be performed in the patients with a low risk CA prostate and with that who are kept on the active surveillance and having symptomatic obstruction. The relative indications for simple prostatectomy are acute urinary retention, persistent or recurrent UTI, severe recurrent hemorrhage from the prostate, severe symptoms unresponsive to the medical therapy, and other are the renal failure, pathophysiological changes in the kidney, ureter, and bladder secondary to BOO. Contraindications for the for the simple prostatectomy include small fibrous gland, presence of significant prostate cancer, and previous pelvic surgery that may obliterate access to the prostate gland. The most.
So now just to revise, so can anyone tell me then what are the indications in which you will consider a patient towards surgical intervention of the prostate? As per the guidelines, there are 5 indications. Anyone?
Dr. Numan.
I guess, Numan, you have been selected.
Sir, enlarged prostate more than 80 gram volume with bladder stone with diverticulum. दूसरे नंबर पे वो any medical surgical orthopedic condition which hampers the lithotomy position. Number 3, the patient with symptomatic retention recurrent or
So if a patient is having no symptoms, but he has an orthopedic condition and the transrectal ultrasound shows a prostate of 80 grams, is he a candidate for prostatectomy then? There is clear indications. अभी तो पढ़ा है हमने. इसमें से 5 indications कौन है? Any resident बोले यार. Maybe no one is willing. चलें आगे चलें.
Okay. Before proceeding with the surgery, the most important part is the pre-evaluative evaluation and management of the patient. In the pre-operative evaluation, the history should be taken regarding the symptoms in detail, and the IPSS score questionnaire should be filled, and the examination is done. On the examination, DRE helps in the further management, because on the DRE you have to see the prostatic texture, if it's soft or hard, presence of any prostatic nodule, the obliteration of the median sulcus, or the adherence of the rectal fascia with the prostate. Along with that, some of the investigations that are done in the outpatient clinic include post-void residual urine volume that is seen by abdominal ultrasounds, UFM, serum PSA levels, transrectal ultrasound. Transrectal ultrasound is not always indicated, but it gives the rough estimation of the size of the prostate and the lobes of the prostate. The cystoscopy is indicated in patients with the hematuria, suspected urethral strictures, bladder calculus, or the diverticulum, so that the appropriate approach can be choose for the open prostatectomy. It also confirms the presence of the large median loop. The evaluation of the upper tract is should be done if there is renal dysfunction, recurrent UTI, or hematuria is present. The counseling and consent, again, the most important part before proceeding with the surgery. And this patient, and this you have to tell the patient about the benefit and risk of the surgeries. First, starting with the benefits, you tell the patient about the improved urination. Then all the risk factors that are associated with a simple prostatectomy, such as urinary incontinence, impotency, retrograde ejaculation, UTI, injury to the adjacent structures, bladder neck contractures, need for multiple blood transfusions, and urethral strictures are tell to the patient. Some untoward effect of the simple open prostatectomy, such as DVT and the pulmonary embolus, should also be explained. If the patient is going for a robotic or the laparoscopic approach, you should tell the patient that there is a significant risk of converting to open in case of the massive hemorrhage. Pre-operative preparation, the clear diet should pre-operative preparation for the simple prostatectomy include that the clear diet should be started 1 day before the procedure. Self-administration of the oral bowel preparation the day before the surgery, NPO after midnight, self-administration of the fleet enema on the morning of surgery, and the 1 dose of second generation cephalosporin given before the incision. The sequential compression devices used in the should be used in the lower extremity because of the high potential of developing DVT in the post-operative period, and to minimize its risk. The types of simple proceeding with the first approach is the open approach, and there are 3 types of it. One is retropubic, also known as Terence Venin. Other is suprapubic prostatectomy, Sir Peter Fryer technique, and the third is perineal prostatectomy. Proceeding with the retropubic simple prostatectomy. First, the most important part is the position of the patient. The position is the patient kept in the supine in the mild trendy Lambert position with the slight flex table. Now, starting with the incision and development of the space of the radius. The incision is the vertical midline incision extending from the umbilicus to the pubic symphysis, and then the abdomen is open in the layers. After the incision is deepened through the rectus fascia superiorly above the semi-lumen and below to the transverse fascia. The retractors, that is the which larger retractor is placed within the womb, and it is further it's open to further widen the session. After that, the space of after that, the well-padded malleable blade of the retractor is attached to the welfare retractor for pushing the bladder posteriorly and caudally for the exposure of the bladder in the prostate well. The a space of radius is created by blunt dissection along with the dissection with the help of the Metzgerman and the Becky forceps. Metzgerman season and the Becky forceps. For the enucleation of the human, the most important part is the hemostasis. The hemostasis is achieved by tying the dorsal venous complex at the apex and the lateral pedicles at the prostatoclavicle junctions. The lateral pedicles of the prostate contains the major arterial supply of the prostate, that is the inferior vesical artery. And by taking sutures over both of these vascular supplies, the excessive at the time of ejaculation of the prostate. Now the ejaculation. For the ejaculation of the prostate, a transverse incision is given approximately 2.5 to 2 centimeter distal to the bladder neck, and then with the help of the Metzgerman Caesar, the plane between the prostatic capsule and the prostatic adenoma is created. When the sufficient plane is created, then the blunt dissection started with the help of the index finger, freeing the adenoma both laterally and posteriorly. After that, with the help of the sharp dissection, the anterior commissure between the bladder neck and apex of the prostate is freed. Is done to separate the lateral lobes, and then the fluid is inserted into the posterior prostatic fossa, into the posterior in the prostatic fossa, in the prostatic urethra. Sorry. After that, the urethral mucosa, the strip of the prostatic urethra is separated from the lateral, both right and left lobes, with the help of the Metzgerman scissors. And similar, if there is keeping the prostate within the Babcock forceps, and similarly, if there is enlargement, dissected as well. After the enucleation is completed, the prostatic fossa is inspected for any residual tissue. If present, it should be removed. After the removal of the adenoma, you will inspect the posterior fossa for the presence of any bleeding. If it's present, then the vaginal packs are kept to control the bleeding for 5 to 10 minutes. If after the removal of the packs, if there is still some bleeding present, then the 4 serochromic sutures are used and the electrocauterization is done sparingly. And the other way is to maintain the hemostasis is taking 5 and 7 o'clock, figure of 8 sutures at 5 o'clock, 5 and 7 o'clock positions, and the other techniques of 7 o'clock positions, and then if the bladder neck appears obstructive at the time of closure, wedge resection is performed at the 6 o'clock position. The bladder mucosa advances into the prostatic fossa. Now, the closure of the capsule. The prostatic fossa and the posterior urethra, after the enucleation of all the prostatic adenoma, after the placement of the urethral catheter or Malcott suprapubic catheter, if needed, the transverse incision is closed with the two serochromic sutures. The 2 sutures are tied first to themselves and then to each other across the midline to create a watertight closure of the prostatic pseudocapsule. After retropubic prostatectomy, the second approach is suprapubic simple prostatectomy. The suprapubic simple prostatectomy should be considered in the patients with the intravesical component of the prostate, that is enlarged median lobe, or with the presence of the bladder stone or the large narrow-necked bladder diverticulum. Similarly, as in the retropubic approach, the position is the same. That is the mild trendy landmarks supine position with the with slightly flexible. After the position is made, the patient is propped and grab in the usual sterile manner with and the Foley's catheter of 16 to 22 French is passed, and bladder is filled to 200 to 300 of the saline and then clamped. This will help facilitate the exposure of the bladder. The incision used for the suprapubic prostatectomy is lower midline vertical incision or the transverse penisteal incision. Similarly, as we have created the space of residues in the retropubic approach by the blunt or the sharp dissection using Metzgerman and the Debicki forceps, the malleable blade is capped, which will attach to the Balfour retractor for the exposure of the bladder and the prostate well. Then the stage sutures are taken on each side of the midline at 3 and 9 o'clock position. A vertical cystotomy is made with electrocautery. Several stage sutures are taken along in each side of the midline to facilitate exposure. A figure of 8 suture using 3-0 Vicryl is placed at and tied at the most coral to cystotomy to prevent further extension of the cystotomy incision during blunt finger dissection. Alternatively, a transverse bladder incision can be used. Now, after the exposure after the cystotomy, the bladder is inspected for the presence of any diverticulum or the stone. If present, the diverticulectomy should be done and the stone should be removed. After it is done, a semicircular incision is made at just below the trigone of the bladder from 5 to 7 o'clock position. After that, a sharp dissection is done at 6 o'clock position between the prostatic pseudocapsule and the prostatic adenoma. When the sufficient plane is made by the sharp dissection, the blunt dissection is done with using finger feeding the prostatic adenoma posteriorly and laterally. At the apex, the prostatic adenoma is separated from the urethra by the pinching motion and avoiding the excessive traction with it as to avoid the erosion of the urethra and damage to the external urethral sphincter. After we are done with the enucleation of the prostate, the other important thing is hemostatic maneuvers. The retropubic the difference between the retropubic prostatectomy and suprapubic prostatectomy is that in the retropubic prostatectomy, after the removal of the adenoma, the prostatic fossa can be directly inspected under the vision, and the better hemostatic control can be achieved in comparison to the suprapubic approach. After the enucleation of the prostate, the prostatic fossa is inspected for any residual tissue if found be removed by sharp or blunt dissection. The prostatic fossa is then tightly packed with the vaginal packing and held tightly in prostatic fossa for 5 to 10 minutes. The fossa is then examined for the discrete bleeding site, which can be controlled by electrocauterization of 4-0 chromic suture ligatures. If the bleeding persists even after then, the 0 chromic sutures are used to take 2 figure of 8 suture at 5 and 7 o'clock position at the prostatovesical junction to advance the bladder mucosa into the prostatic fossa to ensure complete control of the main arterial blood supply to the prostate. The other technique of for the hemostasis is the O'Connor technique, in which even after taking the 5 and 7 o'clock sutures, if the hemorrhage persists, the technique explained by the O'Connor is that we can take the placating sutures transversely in the posterior prostatic pseudocapsule. If the hemorrhage remains pronounced, nylon 2 sutures, persistent sutures can be placed around the vesical neck that is brought out through the skin and tied firmly. But this one closes the bladder neck with the tamponade effect on the prostatic fossa. The nylon suture is then removed on second or third post-operative day. Other hemostatic agents that can be used are the microfibril collagen, oxidized cellulose, thrombin soaked gel foam, or commercial or sealants. After we are done with the good hemostatic control,
the basic issue with open prostatectomy is the area where prostate lies. It's behind the bone, anterior to the bone, and very narrow space where it hides below the bladder. From everywhere, it is surrounded by difficulties, and that's why there is element of bleeding. Its blood supply is coming from the cage of bone near all the bones and small vessels, multiple vessels. Its blood drainage is also complex and exaggerated. That's why bleeding is the main issue. Second most horrible issue is closed bladder neck after open prostatectomy. This happens with endoscopic techniques as well, but delayed. In open prostatectomy, post-operative, when you remove fully, bladder neck is found to be closed because of surgical technique. And this all happens secondary to narrow space where you are going to operate upon this patient. So it's very important to understand then that how you will deal it. And the most important step in this is what I realized. Usually, surgeons prefer to give a lower midline incision, and they confine it below the umbilicus, and that's why there is narrow space to operate. Because of that narrow space, they cannot access properly into that pelvic cage. So extending the incision above the umbilicus and do not hesitating in it is better. It's the logic of big surgeons give big incisions that make a proper space for proper surgery and proper exposure. Then you can do proper work. Otherwise, if you go through narrow space, then you will have less vision and less access to the surgery. And it is very important that when you are going for open prostatectomy, your field should be very clear. Without clear field, if you are going to operate and remove prostate, then there will be two horrible complications. One is bleeding and other is closed bladder neck because of improper closure for hemostasis. You see a long list of maneuvers for hemostasis and applying stitches over the prostatic fossa from all the sides, from anatomically from where the blood supply is coming, venous drainage is coming. But in a technique usually observed in OTs here and there, anywhere, is everything is blind. Nobody thinks of applying sutures over bleeders, but the pressure applied by Foley or by packing so that hemostasis can be secured. This is not surgery. Surgery is you are having clear field, you are having clear identification of the tissue and blood supply and anatomy, you are having proper closure, proper respect of the tissue and proper closure, so that your continuity of the tissues is best, ideal, most what you can achieve. Patient should be benefited, not only you to learn how to do open prostatectomy and patient is with catheter forever. This is not the way. So learning better surgery means you should know anatomy in best way. Otherwise, you can't go over there. And then better idea of the steps of surgery and better respect of tissues. And more important is best determination that what you are going to give to the patient. That's how you can go for it.
After placing the perurethral 22 French catheter, the suprapubic tube is also placed, and along with that, a drain is placed at the side on the side of the repair. The cystotomy site is closed in two layers with two observers. The first layer closes the mucosa, involving some muscles, and the other layer to close the detrusor muscle. After the closure, the bladder is irrigated with a saline to see for the to see for to prevent to see for the presence of any hemorrhage, and along with that to see the leak at the site at the repair site of the cystotomy. After everything is ruled out that there is no urinoma formation, there is no leak from the cystotomy repair site, the drain is placed, the pelvis is irrigated with copious amount of normal saline, and complete routine wound closure is done with absorbable suture, including approximation of the rectus muscle. The uterine catheter is maintained on the traction with the adhesive taping on the thigh with intermittent or continuous irrigation as needed. This is the pictorial representation of closure of cystotomy site in continuous fashion with the absorbable suture. The post-operative management for simple open prostatectomy is that in the recovery area, you will observe the pelvic drain and the urethral catheters for the hemorrhage or for the working drain. If there is the continuous bladder irrigation should be done to prevent the clot formation. If there is a persistent hemorrhage after applying traction to the urethral catheter, the patient will take into the operating suite and for the endoscopic inspection of the prostatic fossa and the bladder neck to identify and fulgurate to the discrete bleeding points. If marked hemorrhage continues to persist, re-exploration should be strongly considered. Traction from the Foley's catheter release within 12 hours. The pain management consists of IV opioids till the patient is not fully allowed orally and start tolerating. The pulmonary exercises started on the evening of the surgery, and patient is asked to ambulate 4 times per day on the first post-operative day. If hematuria settles, bladder irrigation discontinued and the Foley's were deflated to 30 ml. On second post-operative day, if the urine is clear, the urethral catheter is removed and the suprapubic catheter is clamped for the voiding trial. The pelvic drain removed if there is low drainage, and on discharge, the patient is advised to gradually increase his activity. With a clamped suprapubic tube, a patient works well with minimal residual volume in bladder. Suprapubic tube removed on first week post-operative day in clinic. If there is only Foley catheter placed, then it will be removed in 1 week after the surgery in clinic. The patient will resume his full activity on the 3 to 4 weeks of the surgery. Outpatient visit done at 6 weeks and 3 months for the assessment of IPSS score and the urine flow of the patient. The third approach for the simple prostatectomy is the perineal approach, and the indication for the simple perineal prostatectomy is in whom the abdominal incision cannot be given, such as the patient with the femoral bypass graft, in which there is a urethral conditions such as urethral structures, and the patient with a greater body mass index. The surgical outcomes of cure, continence, and potency are comparable to the other two approaches.
I think पेरिनेल प्रोस्टेटेक्टमी को स्किप कर दें, उस पे आते हैं एंडोयूरोलॉजी.
Now we are going to discuss about the laparoscopic and robotic simple prostatectomy. The advantages of laparoscopic and robotic surgery over open technique is reduced pain and bleeding, shorter hospital stay, and faster recovery time. And it also allows the better visualization because of pneumoperitoneum and magnification. Indications are similar to those that are for the simple open, and the contraindications include the COPD or glaucoma, and the general contraindications of laparoscopic and robotic surgery. The laparoscopic, first of all, we are going to discuss about the instruments, endoscope, and the surgical materials that are used for the laparoscopic surgery. 0 and 30-degree lens is used. With the 0-degree lens is used in most of the time, and the 30-degree is used at the time of dissection of the urethus or at the time of cutting the urethra. Laparoscopic, ultrasonic, or bipolar scalpels can be used for dissection. Laparoscopic needle holder, a Maryland grasper, and irrigation suction system, atraumatic forceps, laparoscopic blunt adenoma dissector, electrocautery loop. Occasionally, a Carter-Thompson needle is used to externalize the traction suture applied to the gland with median loop for the traction purpose. Absorbable sutures, 30 Vicryl type CT1, 20 monocryl suture UR6 and V-lock sutures are used. Non-absorbable sutures, Prolene 20 CT1 and Nylon 20 sutures are used. And extraction bags is used, and a closed drainage system with negative pressure such as Jackson Pratt type is used. And now the positioning of equipments and for the laparoscopic prostatectomy is that the laparoscopic tower is located at the foot end of the patient. Depending on the hand dominance of the patient, the hand dominant of the surgeon should stand on the opposite side. Like for example, the surgeon should stand to the patient's left or right side depending on the surgeon's dominant. Right-handed surgeons are usually positioned on the left side of the patient. The assistant should stand opposite to the surgeon to hold the camera, and the scrub technician should be located next to the first assistant anesthesiologist at the head end of the patient. The patient position is the trendy Lindbergh position, that is the head lie 30 to 45 degree below the feet with the arms closely approximated along the side of the body. Surgical techniques for the laparoscopic approach is transperitoneal and extraperitoneal. First of all, we are going to discuss about the placement of the trocars. The placement of the trocar, the 1.5 to 2 centimeter incision is made at the level of the umbilicus. There are two approaches by which the trocars can be placed. One is the open Hassan technique, and other is the Veress needle technique. The open Hassan technique is in which the incision is opened in layers under direct visualization for the placement of the primary trocar for the camera. And the Veress needle technique is that in which the Veress needle is inserted into the peritoneal cavity, and the pneumoperitoneum is created first before the placement of the first camera port. The first 10 mm trocar is placed at the umbilicus to provide the optical guidance. The horizontal line just below 2 centimeter to the primary camera port, a horizontal line is made, which will serve as a marker for the subsequent trocar placement. Next, 10 mm trocar is placed on the right side and 5 mm trocar on the left side. These trocars are roughly 8 to 10 centimeter away from the umbilical port. In addition to that, a 5 mm trocar is placed posteriorly on the right side and another 5 mm similarly on the left side. The access to the pre-bladder space. After the creation of the pneumoperitoneum, the uricus and the medial umbilical ligament, which will serve as the anatomic reference, are dissected. Either 0 degree and the 30 degree lens is used. The uricus is dissected laterally along the vas deferens on each side, as well as horizontally up to the promontory above the pubis. Redz's space is developed up to the endopelvic fascia, enabling identification of the periprostatic fat, which can be removed. After the creation of pre-bladder space or the space of Redz's, the prostatic capsule incision and dissection of the adenoma is done. Before that, the lateral prostatic pedicles and the dorsal venous plexus should be identified and controlled with sutures. The prostatic capsule and the bladder are identified. The capsule vertically or horizontally incised as in Millen approach at a transvesicocapsular incision or transverse incision 4 to 5 centimeter is made at the vesicoprostate junction. After opening the bladder, the surgeon must identify the presence of the median loop. If enlarged, A transvasicocapsular incision or after opening the bladder, the surgeon must identify the presence of a median loop. If enlarged or traction suture on this loop improves exposure. The trigone and the urethral meatus should be identified, and a semicircular incision is made with electrocautery loop in the groove between the adenoma and the trigone. Next, the dissection is carried out from the center to the side with the ultrasonic scalpel, carefully sealing blood vessels and lateral complex as the plane between the adenoma and prostate capsule is developed. The surgeon should be subsequently continuously cut the crescent upward to locate the plane between the upper capsule where the dorsal vein complex is located and the adenoma. The adenoma is dissected systematically in synchronized technique using the ultrasonic scalpel or blunt dissector, the suction irrigation cannula, and the laparoscopic scissors. A 2-0 proline suture in the adenoma provides a traction and improves exposure. The suture is used in a fisherman maneuver to help define the proper plane for the extraction of the subcapsular adenoma. Preferably, the 30-degree lens positioned downward or laterally. The prostatic urethra at the prostatic apex should be identified. Care should be taken to avoid injury to the sphincter. The cold cutting should be employed to complete the dissection of the adenoma. Coordination of the traction on the adenoma, counter traction with the suction system, and the positioning of the camera are important during this step to help identify the appropriate level. After the adenoma removal, the trigonization of the fossa is done. The direct hemostasis, the direct hemostatic control can be achieved with electrocautery or suture, that is Vicryl 40 in the area of the capsule that demonstrate active bleeding. The trigonization of the fossa is performed with 1 or 2 double points from the trigone to the capsule or with a monocryl UR6 needle near the urethra. A straight urinary catheter or Foley catheter can be inserted at the stem, 22 or 24 French. 2 deep sutures on each side at the top of the surgical incision passing through the capsule neck bladder capsule to achieve hemostasis. Continued closure should proceed lateral to center with the subsequent tying of both sutures in the midline. After the closure of the prostatovesical incision, the urinary bladder is filled with 200 to 250 ml of the fluid to verify the proper closure of the capsule and the absence of leaking throughout the surgical wound. In the event of leakage, double sutures must be placed in the leakage area to reinforce the closure. An abdominal Jackson Pratt drain should be carefully placed near the surgical incision. Placing the drain directly on the incision may interfere with the healing of the anastomosis. A specimen is removed through the umbilical incision, which can be extended if necessary. A specimen can also be extracted by morcellating the adenoma. The abdominal fascia is closed at the site of umbilical port with 1-0 Vicryl suture through the fascia at the 10 mm port. The skin should be closed with intradermal 3-0 proline sutures. Extraperitoneal approach is almost same to the transperitoneal approach, except for that after making the infraumbilical incision and the space of Redizius is entered under direct visualization with a Visiport device, and this is the diagram showing the Visiport device entering through the umbilical incision into the preperitoneal space. The trocar and the balloon is inflated, the trocar and the camera are removed, and the extraperitoneal space is developed using a trocar mounted with balloon dilator. The balloon is inserted in the preperitoneal space and supplemented under direct vision. Additional trocars are inserted and transaction of the bladder neck occur as one of the initial steps. The remainder of the operation is similar to the transperitoneal approach. Now we are going to discuss about robotic simple prostatectomy. Similarly, in that we are going to first discuss about the patient position, that is the lithotomy trendy Landberg position, and the position of the equipments and person in the operating room. The Da Vinci system, the robot with 3 or 4 arms should be placed between the patient's legs. The first assistant is on the right side of the patient and the second assistant is on the left side. The instrument table is positioned next to the main assistant. The anesthesiologist is located at the head of the patient. Endoscopes, instrument, and surgical materials that are used similar to that used in the laparoscopic technique, that is 0 and 30-degree endoscope, monopolar robotic scissors, Maryland cautery instruments with bipolar photokinetic energy, 1 or 2 robotic needle holders, and atraumatic clamp suction irrigation system, and the non-absorbable sutures. surgical technique that is transperitoneal and extraperitoneal. First of all, the trocar placement, the skin incision of 2 to 3 centimeters is made at the umbilical level, and the first 10 mm trocar that is for the camera is admitted. Next, a horizontal line, similarly as we have did in the laparoscopic technique, that a horizontal line is drawn 2 centimeters below the umbilical incision. The surgeon then placed 2 8 mm robotic trocar that are roughly 8 to 10 centimeters away from the umbilical trocars. The two right side trocars, 10 and 5 mm, are posteriorly placed by the first assistant. Another 5 mm trocar should be placed on the left side by the second assistant. This is the position of the trocars with the 10 mm trocar at the umbilicus, and with the transperitoneal approach, first of all, the development of the space of Retzius is done. The anterior peritoneum is, after the creation of the pneumoperitoneum, the anterior peritoneum is taken down lateral to the medial umbilical ligament to displace the bladder posteriorly. Applying the posterior and syphilic traction on the urachus, the space of the Retzius is developed using both blunt and sharp dissection. Periprostatic adipose tissue is then removed. Endopelvic fascia is taken down carefully to expose the prostatic contour. And next is the bladder neck incision, which is given on the anterior bladder neck, divided transversely using monopolar scissors until the urinary catheter is visualized. After the urinary catheter is identified, it is grasped by an assistant or the fourth robotic arm with the prolapse forceps and pulled anteriorly before widening the bladder neck incision. The better visualization of the intravesical component of the prostate and the trigoon, the bladder neck incision in this approach should be wider and more syphilid. When a large median lobe is encountered, it is lifted anteriorly by the assistant or the prolapse forceps. Bilateral UOs are identified to avoid any injury to them by using either the ureteric catheters or endocarmine dye. Next, the enucleation of the adenoma is done by the help of electrocautery with a robotic monopolar scissor to create a circular incision. The bladder mucosa distal to the trigoon. With the use of the monopolar scissor, the subcapsular plane between the prostatic adenoma and the prostatic pseudocapsule is developed initially at the 6 o'clock position to prevent inadvertent injury to the urethral orifices. While developing the plane between the prostatic adenoma and the pseudocapsule, it is crucial to have an experienced assistant or the robotic fourth arm with forceps to optimize the visualization of the dissection plane and provide traction. In comparison to the open simple prostatectomy approach, the dissection plane should are better visualized at all the times during this procedure. Once a well-established plane is created posteriorly, the prostatic adenoma is dissected circumferentially and inferiorly towards the apex. Using both blunt dissection and limited electrocautery at the apex, the prostatic urethra is transected while avoiding excessive traction. At this point, the prostatic adenoma, either as one unit or separate loops, can be removed from the prostatic fossa and set aside. Hemostasis and the vesical urethral anastomosis is done after the removal of the adenoma. The fossa is carefully inspected and the hemostasis achieved by limited electrocautery or suture ligatures. The vesical urethral anastomosis is performed in a continuous fashion with 2 zero-barbed sutures in a single knot method, which is known as the Van-Valtuin technique. A 20 French two-way Foley catheter is inserted. A watertight closure is confirmed using normal saline irrigation by Foley catheter. A closed suction pelvic drain is placed through the lateral 8 mm robotic trocar set and secured to the skin. Hemostasis is reconfirmed with low insufflation pressure less than 10 mmHg. Adenoma extraction is done by the supraumbilical trocar site. If needed, it can be further extended. Then the closure is done by the vicryl 10. The rectus abdominis facial defect is closed, and the skin is closed by the 30 proline in intradermal fashion.